All right. Well, welcome to Limb Loss Connection, the next step. We're lucky and fortunate enough to have Dr. Mayo, Dr. Amanda Mayo, join us. Know what a physiatrist is or that field. Tell me what got you interested in that and what it's all about.
Sure. So physiatry is also known as a physical medicine and rehab specialist or rehabilitation specialist. And so if you hear PM&R specialist or physiatrist, it's the same thing. And it's basically medical professionals. So we do med school and then we do a residency training in physiatry and specialize in disorders or injuries to muscles, nerves, bones, and joints. And it's quite a broad specialty. So people can specialize in like stroke physiatry, limb loss or amputee physiatry, brain injury, many other different sort of aspects of our specialty, but that's sort of what physiatry is. And I got into it because I was an engineer before medicine. And actually, in my engineering training, I was designing prosthetics. That was back in Guelph as like an undergrad.
Okay.
Actually, a prosthetist that I work with now, RJ Clements, was one of my lecturers. And so I had
Oh,
an interest. Yeah, had an interest in that way back then in 1998. And then became a clinical engineer. So I did a master's in engineering, and that's where I found medicine. I didn't have any exposure to medicine, but being a clinical engineer, you had to sort of shadow and learn workflows and sort of see physicians and patients interacting. And I kind of, caught the bug that I thought, oh, that was something that I'd like to do. So I applied for medical school and did medicine and thought maybe I wanted to go into surgery. As I started doing the clinical training, I recognized that maybe the hours of surgery were not for me,
yeah.
nor were my hand-eye coordination. And so I put in prosthetics in the U of T catalog because you can choose like different rotations, and an elective in physiatry came up at Sunnybrook. So that's where I kind of got back to prosthetics, and physiatry was the path to sort of do that in medicine, and that's how I became a physiatrist.
So you've been there a long time at Sunnybrook then.
Yeah, so I started,
Oh,
when you go through medical school, you do what you call your clinical clerk. So in your third and fourth year, you're kind of at the hospital, one of the med students on the medical team. And so since my third year, I've sort of my home base has been Sunnybrook of med school. And then 5 years of residency, sort of toured around outside of Sunnybrook, and then came back to Sunnybrook in 2013 when I graduated.
they're so lucky to have you. I know that. Well, listen, you just recently took a vacation. I want to hear about it. Where'd you go, and how are you re-energized? How do you feel?
I would say so. I mean, I'm a little guilty. I don't take a lot of my vacations. I do take usually a week over the holiday season because the clinic shut down. So I went to Barbados. It was lovely.
Oh, nice.
The weather, you wake up, it's sunny and no snow.
Yeah.
Uh, when I got back, I kind of recognized why there's a lot of snowbirds from Canada.
Yeah, yeah, we take off down there. Yeah, there's so much snow this year. It's been a crazy winter this year. So tell us a little bit about your role at St. John's. How many beds do you have? How many patients do you typically see in a year? That sort of thing.
So St. John's Rehab, the whole rehab hospital has 174 inpatient beds. As far as beds for limb loss rehabilitation, we sort of fluctuate. It's a 39 bed unit, but it's mixed with cardiovascular. So in our high season, which is usually trauma season this summer, we'll get up to like 25 limb loss patients. Currently on the unit, I think we have 16 or 17. But it, usually sort of goes from 15 to 25, depending on sort of our volumes and sort of how things are moving in the acute care or other, the hospital settings. And so, yeah, we usually probably admit, I'm going to say 50 to 100 new limb loss inpatients,
Wow.
but have a big outpatient program where we're seeing a lot of patients doing outpatient therapy and clinic. And so, a typical sort of clinic week, we'll probably see 30 to 40 patients a week, sort of in the clinics as well.
Right, right. You mentioned, what was it that you just mentioned? You mentioned trauma season. What does that mean? Like, is there more amputees in a certain period of time in the summer, is what you're saying?
Yes, yes, particularly at Sunnybrook because we're the biggest trauma hospital in Canada. Unfortunately, motorcycles, a lot of accidents result in limb loss. And then ATV accidents, people are just out doing more stuff probably at higher speeds than in the
Right,
cold season.
right.
But definitely we see higher rates of trauma in the summer in Canada.
I've got a 19-year-old, and there's no way I would have let him ride a motorcycle just for that reason.
Yeah.
Um, yeah. So, what does cause amputations? Like, what's the main causes?
So in Canada and a lot of the developed world, it is diabetes and vascular disease. So over 80 to 85% in Canada, North America. And we call those types of amputations dysvascular. And so they're really complications from diabetes and or vascular disease because a lot of people that have diabetes have vascular disease.
Right,
And so those are people that get like a diabetic foot infection or gangrene or maybe a painful foot because they've got a blockage in one of their vessels. And so that's the bulk of at least lower limb loss in Canada and North America. The next would be trauma. And so motor vehicle collisions, workplace accidents, falls, unfortunately, sometimes violence or conflict zones. There's trauma that's going on, and then cancer, and most commonly the cancer like Terry Fox had, like a sarcoma,
right,
which is
right,
a bone cancer. But sometimes we'll see people where the cancer is metastasized. So, a kidney cancer where it's gone to the bone, or a skin cancer where it's gone to the bone.
right,
And then there's a smaller group, and sometimes this is the group that's maybe affected um, quite greatly, is sort of like the non-diabetic related infections, or you hear about the septic shock or the sepsis.
yeah,
And so those are people that get quite sick, probably in the ICU, and they just can't send the blood flow to their hands and their feet. And so often those people, it's a small percentage, but they can lose, multiple limbs or
right,
multiple fingers and multiple toes. So those are the main classes. And then there's also individuals with limb difference. So people that were born with a limb difference, and sometimes they have a revision amputation just to make the limb more functional, or they might just have sort of the limb difference that they were born with.
right, right. And diabetes, you mentioned diabetes is on the rise, right? There's a lot more people with diabetes, living with the disease, not even realizing what kind of damage it's really doing. And I think I was one of those patients. Got diagnosed very late in my life. Probably had diabetes most of my life, and didn't look after myself properly. And the listeners probably know all this about me because we've talked about it on other podcasts. But yeah, stepped on something, lost one leg, and soon after lost the other leg because of an infection. So it's really on the rise. What would you say to people that have diabetes that they're kind of new at diabetes, they just got diagnosed? What's the advice that you would give them?
I think you're right. People are just not aware of the impact that diabetes can have on your whole body.
Right,
And some people, again, it's probably lack of public education or just knowledge. Some people think, oh, I'm taking my medications. I don't have diabetes anymore. You do have diabetes. You're just taking medications to try to minimize sort of
right,
the side effects of diabetes. So I think it's really important to recognize that it's a serious illness, like a serious sort of medical condition. And when you sort of take care of yourself and take care of your diabetes, you can sort of lessen the risk of complications like a foot ulcer, like amputation. Of course, some people have, forms of diabetes that are very hard to control. And so it's really sort of a challenge for them. And I think it's really sort of talking to your healthcare team or sort of, your social support team to sort of think about like, well, how can I manage this the best I can?
Yeah.
Because we know that, healthy food's expensive. Some of the medications are expensive, but sometimes I think if you have to sort of step back and sort of recognize that it is a serious medical condition, and try your best to sort of manage it the best you can in the situation that you're at. Because we have a whole range of patients that, just resource-wise, it's very difficult for them to access the best care or maybe sort of, get to all their appointments. But, trying to sort of support yourself and look out for sort of online resources and support groups is helpful as well.
Yeah, we talk about that on our support group, with limb loss, is a lot of people are diabetic and, we offer support to them. It's not just your amputation that you worry about, but you have neuropathy, you have heart disease, you have kidney failure. It attacks all of your body and it's such a silent killer, right? As they say. Well, listen, I want to move into, where patients come into the rehab center. So they've just left hospital, they've had their surgery. Often in that stage, they're not really told what to expect. It's either a live or die situation quite often with sepsis, with infections. We have to take your leg, or the outcome is not going to be good. And so they leave the hospital with that kind of news. They wake up, they don't have a limb. It heals a little bit in hospital, and then they come to you. And what I'd like to talk about is that journey from that point on to the time they're discharged and beyond. Okay, so when they come to you, that transition, what's it like for someone to first arrive at Sunnybrook, and how do you make them feel a little bit more at ease?
Sure. And I think, the pathways is a little bit different depending on where you live. So I'll talk about sort of our center, because I know some patients and some individuals don't have access to inpatient
Right,
rehabilitation. But typically, if you've had a major limb loss, so something, ankle above, for the lower extremity or the legs, you'll come to inpatient rehab. If everything's gone well, maybe within a week of surgery. We can't take anybody on any IV sort of pain medications, or, you have to be medically stable. And I think sort of when you come, it can be a little bit overwhelming because there's a big team.
yeah,
And so you're meeting sort of your physicians and your occupational therapist, physiotherapist, social worker. Then we have a team coordinator. And so the first day or two, patients are getting to know the team and the team's getting to know them. We do try to offer peer support, and sort of recognize groups like Limb Loss Connect. And then also, we have psychiatry on the team. So we have some consultant services. They don't automatically meet patients, but we do have two full-time psychiatrists that can be quite helpful for people. And I think just sort of seeing where they're at, because some patients, they might have expected this for whatever reason, maybe their health was declining, or they've had sort of a relative or a friend that's lost a limb. And so they kind of know. But we have a lot of patients, like you said, Kevin, that are in a bit of shock.
right,
And sometimes, they seem like they're coping well when they first come. And sometimes it's different sort of stages in the journey where, their mood might dip, or, it's easy to get frustrated because your sort of abilities have changed, and you're learning how to do things in a new way. And so we try to, see where patients are at and try to get them sort of the best supports that we can. We'll usually have a family or a caregiver team meeting sort of midway through the inpatient admission just to start planning. Because depending on where you live, you might need to make a lot of changes to your home.
right,
And some patients we need to sort of find a discharge destination, right? Like they just might not be able to go back to where they came from.
right.
And so we try to plan early, and then also trying to decide whether they're going to get a prosthesis during their inpatient stay. Maybe that's not a goal for various different reasons, maybe level of amputation or just how their health and function is. And then planning sort of what the care is going to be like after they go home. So whether, they're going to do outpatient rehabilitation at our center, but we get people from all over. So sometimes we're just trying to, make some care connections outside of the GTA as well.
Yeah. Yeah. I went through that process with you. And when I first came in, I was actually shocked. I started my rehab at a regional hospital and found that it just didn't suit me. It didn't meet my needs in sense of like, I didn't feel like I was really learning much there. And so I contacted you and you accepted me into the program. And I was shocked at how welcoming it was. It was like, it wasn't just you in the room, but a wound nurse came in, a PT came in, occupational therapist came in. Everybody was there, a whole team. And it felt good because at that moment I knew I was in the right place, you know? So, but you do go through those stages. You mentioned a psychiatrist, and I want to move into a little bit, talking a little bit about the mental health and the emotional side of things. Um, it's not just, it can hit you at any time in the journey. And when I know that in the beginning, I was kind of prepared, like you said, for my amputation. I knew that I was gonna lose my leg. I tried to save my leg for almost, I think it was like 4 years, with my toes cut off, then part of my foot, etc. And when I finally got through, or when I finally came to you and I said, well, we need to amputate, sorry, when I came to the surgeon and said, we need to amputate this thing, it was kind of a life or death sort of thing. It was getting infected and, there was no choice. But I hit an emotional point in there where I was very depressed, sad, didn't know what my life was going to look like. And talking to a lot of people on our support group at Limb Loss, as well as on the podcast, a lot of people go through that right off the gate, right in the very beginning. They don't know how they're going to function moving forward. So talk to us a little bit about that. The emotional aspect of it and how it really shakes up your identity. What do you see in patients? What do they struggle with the most at that point?
Well, I think every patient is different. And sometimes, patients are quite resilient, and, maybe don't have the same dips as others. And I think there's different things that can sort of change a person's mood. And so sometimes, people are in a lot of pain after the surgery. You're not able to do things maybe independently, and that's a challenge, right? You
Yeah,
imagine you've done things on your own, since you're an adult, and so now, that sort of sense of dependence can really weigh on people.
right.
And I think a part of rehabilitation is really like optimizing function. And so, and whether it's, maybe independent with assistive equipment or sort of a different way of doing things, but that's sort of really a goal is how we can optimize function. And then there's, I would say, a fairly significant group body image.
Yeah,
And there's a lot of research coming out about particularly like males and females. And, there's different aspects of quality of life that are important to people. And so I think as we start to study limb loss and sort of mental health post limb loss, that there's different sort of goals for people, and body image or sort of getting back to integrating into the community can be a little bit more difficult, and same with different cultures, right? So it's trying to sometimes find how people are stuck, because I think when you're stuck in that low mood and depressed, then it's hard to do the exercises and it's hard to sort of, think your way out of that. Maybe, sitting back and listening or trying to, I always say we can't assume because every patient is different.
right.
And sometimes it's maybe, if they're open, can get some other information from people that know them better, that
Right.
know them sort of pre-limb loss and sort
Yeah.
of what's changed.
Yeah.
And sometimes that can help. But then I also think like a lot of research evidence for peer support. So it's great, this group that you formed. It's really, really helpful because people are down the road in the journey and the peers are the ones that have really experienced limb loss versus most of the clinical team.
Right, right. And it's great on the calls because the people that are 5, 6, 8 years into it can really give a lot of good advice to the people that are, brand new to limb loss. So we're finding that. The other thing is there's a moment in time that there's a shift I find with when I'm talking to these people that they start to believe in themselves. So they either sit in their wheelchair, they kind of mope around, they're like, not doing their exercises, et cetera, et cetera. But then they start to see when at St. John's anyway, what I notice is they start to see other people progressing, people walking by with their prosthetics or whatever. And that's kind of a shift for them. They start to get motivated and say, yeah, I can really do this. So that's really nice to see. I want to move into wound care and early recovery. So wound care is really critical, right? They come out of the hospital. They're I don't know if you want to call it the stump or people have different names for it, right? But it's not quite healed yet. There's still stitches and staples in it. How important is it to really look after that wound, and what is some of the advice that you would give to somebody that has to go through that?
Yeah, so I think it's something that you need to sort of expect is that you might have a wound after you're going to have a wound after surgery, and typically they take a bit longer than if you just sort of cut your arm or maybe had sort of a broken ankle and had surgery, just because the residual limb there's a lot of swelling and they make these sort of flaps, and so there's some tension on the wound. So typically you're going to need wound care. And it could take, 4 to 6 weeks to heal, 6 to 8 weeks to heal.
Yeah,
But we have some patients that, particularly if you have diabetes and vascular disease, sometimes it takes months and months to heal.
yeah,
And patients maybe don't realize that. And so it's important, particularly if your wound isn't healing well, to, seek the attention of your surgeon or, maybe your physiatrist who's looking after you in the rehab center. Um, and then we also use sort of special socks like compression because that can help to shape the residual limb, but also reduce like when your leg or your arm is really swollen, that can pull on the incision as well. So we're using the compression not only to shape, but also it's an element usually for wound care. But having a good nursing team is sort of critical.
yeah,
And sometimes I think patients maybe are home struggling and not knowing who to reach out to. But if you just had surgery in your home, reach out to your surgeon's office or, if you have a family doctor, reach out because they'll be able to connect you with sort of nursing care in the community, or, they might have a look and sort of you might need antibiotics or sort of other treatments for your wound.
yeah. The wound, like the bandages, it has to be redone almost every day, right, or every second day to really look after it and care for it. Um,
Yeah, it depends on the dressing too. Sometimes if
oh,
they have, yeah, if they have like there's different ones, like there's hydrophora, there's some that we actually stay on for like 2 to 3 days just because they're doing something to the wound bed to get it cleaner.
yeah,
But yeah, you sort of you got to make sure that someone's checking it. It's just like if you're
yeah,
diabetic or you have vascular disease, you're always trying to check your feet. So same thing, checking your residual limb. The skin of your residual limb is important even after it heals, right? Because you can get wounds and stuff later on. So always good to have a check, maybe with a mirror.
yeah, yeah, for sure. And especially when you get your prosthetics, you can get little wounds on there. I mean, I've had it happen to me, and I call it setbacks because a small
Yes,
wound could
yeah.
turn into 3 weeks in the wheelchair again. So we try to avoid it. Yeah. So how do you keep them on track? Well, limb loss, we like to go to the hospital. We like to go pay visits in the hospital. We do a virtual session with your team, with your patients. We do peer one-on-one support. It's really, really critical for that. After they, while they're in the hospital, but after they leave the hospital as well. So I always like to talk a little bit about that. You also mentioned diabetes again, and I remember one of the things that resonated with me is how often I got told by your nurses and whatnot to really watch the sugars, or your glucose readings. It was almost, every meal they were testing my sugars and making sure that I was on track and whatnot. How important, like what's the significance of high sugars or glucose in your blood? What happens to the wound at that point?
So if you have high blood sugars, it does put you at risk of not healing wounds.
Right.
I always say bacteria likes sugar, and so it can cause like a wound infection, but also just progression of the poor circulation, right? So when you have high sugars, it can sort of lead to those blockages in your little blood vessels in your feet. And then we're also, as we talked about earlier in the podcast, worrying about sort of the vessels in your heart and the vessels in your brain. And so trying to keep the sugar in control is important. The sugar is also toxic to the nerves, and so that's why people get neuropathy, which is sort of a loss of
Yeah.
sensation in their feet. And sometimes when it progresses, it causes weakness, right? Like it can cause people to get a foot drop where they can't pick up their foot,
Right.
or maybe go to their hands. Their hands start to get, weak and clumsy and sort of numb. And neuropathy can be painful. So
Yeah.
we know that good sugar control can try to reduce that sort of burden on the body. And we recognize like there's a lot of adjustments usually if you've had a limb loss from amputation, because often your sugars have been riding really high because you've had an infection or sort of, a bad foot for a bit. And so after you have the limb loss, sometimes there's a lot of sort of optimization of your sugar control because things are sort of, just getting back to normal as far as your body, because you've cleared that infection and sort of stress on the body from the foot that's either had gangrene or sort of a diabetic foot ulcer for some time.
Yeah. Yeah. Neuropathy is painful. It's there's not really a lot you can do about it from a pain perspective. I always worry when I talk to people and they mention that they've got neuropathy. The first thing that goes to my head is you're going to lose your limb if you don't really keep an eye on every cut that you have, right? So let's move into the next topic, and it's really around the daily routine of exercise and how important it is through the rehab process of exercising every day. How important is it, like, to get a routine, and what do you guys do at the rehab center in St. John's for that?
So for us, it's really our physiotherapists and our occupational therapists and their assistants that are sort of going through exercises. We're always trying to meet people where they're at. So sometimes, it's exercises in bed. We also have the hand cycles that are actually really good for building back up cardiac fitness post limb loss, particularly before you start getting standing and walking, if you're going to be standing and walking. But we do set sort of like exercises and we have exercise sheets, and really trying to sort of, educate patients that's important to keep moving. Because one is just general fitness, but it's also your mobility, right? Like if you're sitting a lot, your hips and your knees, they get really stiff.
Yeah.
And that can sort of impact your ability to get up and out of bed, right?
Yeah.
And so really sort of exercises, stretching, just, trying to keep as mobile as you can is important. Um, Diabetes Canada and sort of, Health Canada says that people should be getting 150, so 150 minutes of exercise a week. And so then it's like, well, how do you chunk it out? And when we look at sort of exercise, it's really snippets of 10 minutes or more are known to have
Yeah.
benefits. So if you can try to just get in like little chunks of, 10, 20 minutes, sometimes, that's a lot better than nothing.
Yeah. Yeah.
And then Diabetes Canada diabetes, yeah, they also have like for resistance training. So resistance training, which is sort of anything, you can use like those exercise bands, hand weights.
Yeah.
Some people use soup cans. But Diabetes Canada has a lot of sort of resources that we sometimes direct patients because you want to get your heart and lungs sort of going, but it's also important to do strength training so you can keep your strength up again to stay mobile and healthy as you age with limb loss.
Yeah, what surprised me, Dr. Mayo, is the amount of strength in the upper body that you need when you lose your limbs. It's like when you're trying to get up out of a chair, you don't have that leverage anymore, and it takes so much more energy when you've lost a limb to move around. The other thing that comes to mind is the importance of keeping your limbs straight. So you sit in a wheelchair for so long and you droop your remaining part of your leg downward, and it's hard to stop that from stiffening up and not being able to get a prosthetic on in the long run. So that was the other thing. How important is it to keep going? Like after you leave rehab and get discharged, should people continue that routine of exercise? I'm sure the answer is yes.
It's really important. There's a lot of studies that show that people's mobility and independence declines usually after they wrap up the rehabilitation,
Yeah,
the supervised rehabilitation. So I think it's important to know that, keeping up your exercise and sometimes it's just trying to find a way to do it, right? Like,
yeah,
so sometimes it's joining a group or, setting a schedule for yourself, and you have to recognize that it's not perfection, it's progress. And so
yeah,
if you do it 2 days a week, one week, and then you up it to three, or you're going 10 minutes to 15 minutes, but it's overall health, right? Everybody sort
yeah,
of should be exercising and staying mobile. Everybody should be getting that 150 minutes. But as people age with limb loss, you're more prone to getting arthritis and sort of falls. And so it's kind of critical that you keep up your strength and your mobility as best as you can. And everybody's sort of in different situations, but just keeping that in mind that particularly if you're a lower extremity amputee, as you age, you sort of are just more prone to sort of back issues and hip and knee issues. And so it's important to keep the muscles around the spine and the joints strong and mobile.
yeah. And it's kind of easy to do, right? You wake up in the morning and you do your stretches. It's right in bed. You do your leg stretches and lift your limbs and stretch them out this way and that way. And then you get up and you start your day. I like to immediately have a coffee and then I start to lift my weights and do my upper body. But it's so easy to do. Like you could be watching a television show and you grab your weights and away you go for 20 minutes. It's not that hard to do. I think a lot of people just have to get that motivation to keep doing it. Uh,
Mm.
yeah, so let's talk a little bit about the next phase, and in my mind anyway, and that's casting and getting your prosthetic, like getting fitted for your prosthetic. So once the wounds heal, or it doesn't have to be necessarily fully healed, I think. You then you and you've gone through all your exercises. Keep doing those. You hit the next stage, which is really casting and fitting your prosthetic. Walk us through that process of what that's like, what the experience is like.
Sure. So I think for at least in Canada, the team needs to agree that, we talk about prosthetic candidacy. So it has to be sort of determined by, the physician, the therapist, and the prosthetist, and also the patient, right? So we have some patients that, maybe they're more comfortable in a wheelchair just for other health issues or whatever. And so we sign all the funding paperwork. Every province is different in Canada, and the States, of course, is different to get sort of funding for the prosthetic limb. And then we talk about shape capture. So traditionally, the residual limb is casted. Our center and many other centers now are moving into some 3D scanning when appropriate.
No.
But that's sort of the shape capture phase. And then you need a certified prosthetist. And so they go through a training program to be certified. They'll then sort of, look at sort of the shape capture and maybe modify it just because they've, sort of landmarked out everything with the bones and the residual limb. And then we make a socket, and typically people will start with a thermoplastic or a temporary socket, and usually like loaner components, so like a loaner foot or a loaner knee, or for the lower extremities, just to get people up and going.
Right.
And then as they start to mobilize, maybe working with their process to see what components would be best for them, depending on their activities and sort of funding and environment. And you might get sort of your components like fairly quickly, or we have other people that are maybe trialing different components and get, their final components down the road. But every center is different as far as like turnaround times and how they fabricate.
Yeah.
But traditional methods is sort of hand casting, and they actually like pour a plaster cast. Like there's a lot of different molds and stuff that go behind the scenes.
Yeah.
We are working to more sort of digital fabrication where we're scanning and 3D printing. One is quicker. Another is it's more environmentally friendly,
Right.
and probably more patient friendly because we're not putting any cast on anybody's residual limb and pulling it off. But
Right.
that's sort of where the field is moving.
That's really interesting, the 3D printing. I know that I talked to you several months back. I think you guys were just starting the program, but I can't remember. How long have you had the 3D printing going?
So we started with a study in 2018, actually,
Yeah.
with a very simple FDM printer. So that's the one where the filament goes around, and really just like sort of checking fit sockets. Like nothing, we weren't producing anything we felt confident people could be walking out the door with the technology and just sort of the project that we had at the time. I've actually set up a few sites in the Ukraine with the FDM printers, and the quality's gone way up and using sort of a
Yeah.
different material. And seeing sort of the guys running in those sockets is great to see.
Right.
And then in March 2025, we launched an HP Fusion, which is a fusion jet printer at Sunnybrook. We were quite blessed to get that funded and installed. And that just, when it prints, it looks like it's not 3D printed. Like
Right.
it looks like injection mold sort of plastics.
Right.
And so now we've actually hired an engineer scientist to really start to, doing some strength testing and sort of really sort of making sure that the sockets are the best they can be. But it's sort of an exciting sort of part of our research at our center, which is sort of taking off with the investment in the fusion jet.
Is that unique to Sunnybrook, or is that like, are other people looking at this as well? I'm sure.
Yeah, I mean, the FDM is a lot more accessible as far as space that you need and price point for sure. The Fusion Jet, I think we were the first hospital prosthetic and orthotic team in Canada to get one,
Wow.
but there's other centers that are getting them, and there's other sort of non-hospital prosthetic and orthotic companies that are using them. So they're quite exciting, and there's all kinds of different sort of 3D printers that have different uses, and we know prostheses have a lot of different materials, and so I think we had a Canadian, we call it digital fabrication, which is sort of 3D printing workflow. We had a meeting in October that Sunnybrook co-hosted with Blurview, but really just sort of seeing where the field is at and how we can sort of expand the uses of 3D printing in prosthetics or orthotics. So I think the future is bright. I think with
Yeah.
anything, the technology is there, but how do we make it so that it's used the best way and also accessible to people, not only like patients, but also clinical teams, because sometimes there's a lot of resources that go involved in sort of, developing a digital workflow.
Right. Right. It must be, well, I mean, that's really exciting. It must be really, fun to be a part of that for you. Um, what's it like when you see somebody for the first time walk again? What do you have any stories that you can tell us? Like somebody that's put their prosthetic on the first time, they hold those bars and they take a couple steps. What's it like to you to see that?
I think it's always great to see. I think it's something that you never sort of get tired of because you know where people are coming from. And it's always fascinating to see how people pick it up, right? Because everybody does it at different rates.
Yeah.
But we have some patients that, put the leg on and, we're telling them to slow down.
Yeah, they're
Uh,
walking out the door.
yeah, they're out the door. I think particularly the ones that we've known they've had a really tough road to get to us or to get to that step. I think those are always the ones that were the whole team sort of just really, really excited. And of course, you see the ones where either our team member or maybe one of their partners or family members are videoing them, and that that's telling people that aren't able to see the gym that they're doing okay, right? They're on the right track and
Yeah.
things are moving forward. So it's always a great day to see people up and sort of walking for the first time.
Yeah, so rewarding, right? So, Dr. Mayo, I'd like to move into the next part, which is really talking about caregivers and the family. You mentioned earlier that that's part of the rehab process. You got to bring them in and have a family meeting with your team and whatnot. Um, my wife became my support, and I know that I couldn't do it without her. She was there for every step of the way, and I really, really, really appreciated that. How important is it to have people in that process to kind of support you as you're going, a family member, caregiver?
I think yeah, I think it's really important. Better outcomes are associated with it, but also recognize that often we have those team meetings and there's nobody else in the room. It's just the individual with limb loss. So when we see that, we try to get outside caregivers as far as home care or other supports. But if you do have a family member or a partner that can sort of attend meetings or maybe come to your appointments, it's often quite helpful because it's a lot of information to take in, and it's also a lot of planning and sort of changes, whether it be your home environment. For some people, it's their vehicles or their transportation and how they're getting around. And so it's always great if you have a support team that can sort of, join you and also sort of help, because that's another thing that's hard to do, right? When we talk about adjusting post limb loss is maybe recognizing that you need assistance or help with aspects of your life that
Yeah,
you never even thought you would need help with. Meals and sort of shopping immediately after a limb loss can be a bit of a challenge. The Canadian winter, right? So as far
right.
as like getting outside and in the community. So really, if you can and you've got a team around you, it's great to sort of have them join you when you can, sort of to have a second set of ears and eyes. And, some people are, looking up sort of things on their phone or, there's just there's
Yeah,
a lot of sort of moving pieces when you initially lose a limb. They might be helping you sort of get resources in the community,
right.
tax credits and sort of other stuff. So if you have a team, I always say try to let them in and let you support them, and recognize that I always say if people have big teams around them, it's because they've given to those people in the
Right,
past, right? It's
right.
sort of it's a sign that sort of you've got a good support system for a reason, and now is the time to sort of call them in
Time.
and get their support.
Yeah, it's time. You have to call on a favor. There is a balance there too, though, right? Some people, like when they leave and they want to do their own activities, they want to figure out how to adapt themselves, right? I will figure out how to get in and out of the shower. I will figure out how to get out of the bed. So there's a balance for the caregiver to say, okay, when to let them try it and when to jump in and help them. That's what I've heard anyway from a lot of people.
I think everybody's situation is always different, right? And so sometimes there's fear on the individual with limb losses side, or maybe fear on the caregiver side. And then just also recognizing the dynamics of every relationship, right? And so sometimes maybe the spouse or the partner is not the best, is not the right caregiver, the right
Sure.
fit.
Yeah.
And your relationships and sort of caregiving dynamics can change over time.
right.
And again, if something's not going wrong, maybe you reach, and something's not going right, maybe you reach out to your care team or, your clinical team and try to navigate sort of to see how things can go better
Yeah.
once you're home.
Hmm. Okay, well, that brings us to, I think, kind of the one of the last phases, and that's just discharge, right? So how do you prepare people to go home, and what have you seen, from people that they're nervous about going home, or they just don't know what to expect? How do you prepare them for that?
Again, we try to have a team meeting or a family team meeting, caregiver friend team meeting to start planning. And then depending on the individual, getting the supports in the community that they might need. So some individuals might need home care nursing, they might need a personal support worker, occupational safety, like home safety assessment. Um, they might come to our center for outpatient rehabilitation if that's accessible for them, or can we connect them with care in the community?
Right.
Because sometimes, we get people from like Collingwood Hospital. They're not going to be coming down to
Yeah.
Toronto for their rehabilitation. And then same thing, linking them up with maybe a more local prosthetic clinic, trying to make sure they're connected with peer support. It's a challenge now with family doctors,
Yeah.
but if they've got a family doctor, sending sort of an update to the family doctor so they know that they're home and sort of this is what's happened, this is sort of what we planned. But I think it's always like, um, there's always room for improvement. And so, you're always learning and sort of saying, and new sort of programs are coming out and sort of new services, new equipment. And so trying to keep on top of that as we sort of navigate people getting home safely.
Yeah, that's for sure. And one of the things that we've worked on is when they're discharging from the hospital or the rehab center, is get them support through us, through Limb Loss Connection, get them on the virtual calls, get them talking to other people. And from what I've read, there's better outcomes. Longer people live longer when they have that kind of support, is some of the studies that I've read, which is just amazing, right? So it feels good that we're doing that, and feels like we're actually contributing to a good cause. Yeah. So just to wrap things up, Dr. Mayo, what I know you talked a little bit about the 3D printing and how much it excites you. Is there anything else in the rehab medicine that's taking place that really just gets you up in the morning and say, this is amazing that this is happening?
Yeah, I mean, I like the 3D printing because as I said, I am an engineer, so I feel like I'm getting it back to, especially now that I have a PhD sort of engineering scientist with me,
Right.
and he's fantastic. I think we're always sort of, pushing the limits with different types of surgeries for residual limbs, whether it be nerve surgeries, and same with innovations in prosthetics. We don't have any prosthesis on the market now that has any sort of form of sensation, but I do think that's probably coming, right? Whether it be a pressure sensor or sort of something that allows people to touch with a prosthetic hand. Um, we know that conflict sort of drives prosthetics. The first sort of modern day prosthetics came from World War I and World War II. And that's sort of driving the space now as well. And it benefits, the limb loss population as a whole.
Yeah.
Um, you always wish there was another reason, but um, I think there's an exciting sort of field ahead as far as artificial intelligence, smart prosthetics with
Yeah.
sensors and sensation. Um, the only sort of fear I have is how accessible is the technology. So I
Right.
think, that's the sweet spot. If we can get something that's, really innovative and sort of, elevates people's walking or the use of their prosthetic hand or limb, but it needs to be affordable and accessible,
Yeah.
or it needs to be funded. So sometimes that's where it gets lost because tech companies and there's a lot of sort of money that goes in, I'm sure, to
Absolutely.
creating those limbs. But then how do we sort of make it so that they're accessible for most?
Yeah, you see it all over the internet, hands moving and fingers moving, and it's amazing what they're doing. But then you look at the price tag and it's like, oh boy, I don't think we're going to get one of those.
Yeah, yeah. Well, and sometimes there's other things too, right? Like they're really heavy or there's
Right.
just other factors. And I also see, and it's with everything with AI, like some of it I don't think is real yet,
Right.
right? Like um I get emailed or sort of somebody sort of Googled something, and then, you can clearly see from the website that the prototype that they're showing is really
Yeah.
clunky and whatever, and then they're showing you something that's like, oh, and join our wait list because we're coming to market soon, and it's
Yeah.
like, well, this doesn't really look like,
Yeah.
they're not coming to market too soon.
Yeah. You have to be
But
careful.
I think, in time.
Yeah.
Yes, yeah, because you don't want to get your expectations higher than what reality is currently.
Yeah. It's funny because we've had this conversation several times on the virtual calls that we do, because we do it in North America and Canada. And North America has all kinds of different prosthetics out there. And we always ask, why can't we have them up here? Well, I know that from what I've learned is that we really wait until the technology is proven in the market, and some of those down the states might not meet the requirements that the government's really looking for up here, and that could be why we're not getting them. Do you think that's true, or?
I think it's a little bit opposite as we're a smaller market. So I was just at a conference in California in the fall, and it was more of a sort of wound care conference. But it was interesting. They'll go for the US sort of FDA approval because they know that's like their big market.
Right, that
And
makes sense.
then they're like, oh, like, it's, yeah. And I think particularly with now the political climate, so yeah, we do get usually like some of the prosthetic devices, people will see them at the trade show and then they might come to Canada like a year or two later because they're really getting their FDA approval first.
Yeah.
And for sure, like they've been tested, they're safe, they're everything. And then just because we're a smaller market or sort of an out of country market, and then some of the, the two main companies are actually, in Germany and in Norway or Iceland, right? So, yeah, it's just, I think love Canada, but we're small. And so sometimes
Yeah.
these companies are like, oh, well, that's just, another sort of, because everybody has to go through the Health Canada sort of approvals and,
Right.
and then getting sort of, for us, it's like struggling with the funding codes, right? Because the funding codes in most provinces are quite outdated.
Right.
And so, the technology could be there, but then you don't have the funding. So it's always a bit of a battle that I think being a smaller market that we're dealing with.
I wonder how we change that. I wonder how we get the government to recognize that we need more of those codes put in for different products. Is that a is that something
Yes, yeah.
you go to
I think it's a
Parliament?
lot of advocacy.
Yeah.
Yeah, I think, advocating and updating and particularly like some of the partial hand devices, like they just weren't invented when the last funding guide came out.
Right.
So there's things that are just off the guide. And so hopefully with time, the guide gets updated.
Well, we'll have to work
It's
on
from
that.
2012.
Yeah, we'll have to work on that.
So
Listen,
a lot of things have been invented since 2012.
yeah, exactly. Well, listen, last question for you. What do you feel that St. John's has to offer? Like, what is it that makes it a special place?
I think our team, so having such a big multidisciplinary team, a lot of clinicians, we're very fortunate.
Yeah.
And the fact that we have inpatient and outpatient rehab, and inpatient rehab is where a lot of patients make those sort of peer connections, right? People
Right.
stay, they make new friends and sort of a new social circle. So we're really blessed to sort of have that inpatient and outpatient rehabilitation. And then also the connection with the acute care hospital. So we have dialysis now on site and sort of nephrology that's coming to see patients on site, psychiatry. We have a lot of different services that we wouldn't have if we weren't connected with such a big hospital system.
Right. And here I thought you would say the food.
Nah, not the food for sure.
That's typical for any hospital,
Especially and
right?
not the cafeteria hours.
Yeah, exactly. And
Yes.
I would say what makes St. John's special is you. You're very empathetic, you're very responsive, kind, very accessible. And, a lot of us that have gone through the program there feel the same way that it's just amazing to have you part of our lives again. And so we appreciate that. Um, I want to say thank you to you for spending some time with us today and sharing your insight and covering so much off here that our listeners are going to benefit from, and we really appreciate it. So I know I said the last question, but I want you to comment on one more thing. I heard that you're a dog lover and you have this sweet dog. Tell us about your dog.
Sure. So I have she's 5 now, and she's a Newfoundland that I adopted in April 2021. So in the height of the pandemic, because she has bad hips, so bilateral hip dysplasia. So she
Oh,
actually has her own she has her own dog physiatrist, Dr. Roland, who I'm very thankful for, that takes care of her hips. And she goes so the importance of exercise, even for dogs.
yeah.
She goes for a water treadmill therapy every week. And she's a sweet Newfoundland, very goofy, and we're trying to get her lower than 122 pounds.
That's funny. Yeah, so beautiful. Thanks again, Dr. Mayo, for spending time with us.
All right, well, thanks for having me, and keep up all the good work with the peer support.
Thank you.